Thank you very much. It says 15 minutes here. I think it's 25 minutes in the program, or hopefully 20 minutes at least with the discussion. It was 10 minutes discussion also. So I think you need to adjust the timer, please, otherwise.
Yeah. Can you please adjust that timer to 20 minutes from 15?
Pardon?
No, I'm just asking them to adjust the timer.
Thank you very much. So, safety of growth hormone treatment. These are my disclosures. And this is a disposition. I will try to cover both effects on glucose metabolism. It's good to have slides also. So I can meanwhile say that I will discuss safety from glucose metabolism point of view, cancer, the risk of diabetic retinopathy, cardiovascular conditions, intracranial hypertension, and thyroid metabolism. And here is a slide where it shows how growth hormone affects the cell. And the cell is affected in many different ways by growth hormone and IGF-1. So it has important effects on the muscle. It has effect on the bone, of course, on adipocytes, and thereby affecting insulin sensitivity. Then we're coming to glucose metabolism, and it would facilitate with some slides, but in sake of time, I continue without them. So growth hormone therapy has been associated with a reduction in insulin sensitivity and a decrease in glucose uptake and an increase in lipid oxidation. And we also know that in the muscles it causes insulin resistance. There are conflicting evidence regarding whether growth hormone will in the long term affect insulin sensitivity. There has been described both that this is reversible and irreversible. So when it comes to diabetes, there is a lot of evidence today that there is no increased risk of neither type 1 or type 2 diabetes in patients receiving growth hormone therapy. Having said that, it is difficult with type 2 diabetes because, as you all know, including in India, I think, type 2 diabetes is becoming more and more common, so it's quite difficult to distinguish whether this increase is related to growth hormone or not. However, in patients who are predisposed to type 2 diabetes, there is an acceleration of this development when you treat with growth hormone. So monitoring glucose before and periodically during growth hormone treatment is recommended, especially in risk groups. And what are the risk groups then for insulin insensitivity? Well, one of the indications, Turner syndrome, their glucose metabolism should be closely monitored. Also in patients with SGA and Prader-Willi, there you should focus on glucose metabolism. Now we come to important issues like cancer, and I hope we can get some slides. We do now. So with regards to cancer and growth hormone treatment, please let me know if that disappear. Does growth hormone promote cancer development? Well, there are a lot of data and literature that suggests that maybe this could be the case. First of all, we have an ability of growth hormone and IGF-1 to promote cell proliferation and enhance cell survival. And then secondly, growth hormone and IGF-1 induces resistance to chemically induced carcinogenesis in transgenic animal models. And we have learned a lot from growth hormone resistance, Laron syndrome. These patients they do not develop cancer. There was a recent paper describing more than 200 patients with Laron syndrome, and not a single patient had developed cancer, in contrast to sibling controls who developed cancer at a similar rate as the general population, suggesting that at least a deficiency of growth hormone is protective against cancer, which doesn't show that treatment or pharmacological treatment of growth hormone will enhance the risk. And finally, a link between growth hormone and high IGF levels have been described in many different cancers. So when looking at this, you think maybe there is a risk of cancer connected to growth hormone treatment. Well, how could we know? First of all, there are more than 10 observational studies that has been ongoing for more than 30 years, and in total more than 500,000 patient years reported. Here it is important that in these observational studies, patients have been followed during growth hormone treatment, by average 3.5 to 4.5 years, but not post-treatment. And before going to the next one, I would say that in none of these reports an increased risk for a primary cancer, in other words, a new cancer in a patient treated with growth hormone, has not been described. The first and only real long-term follow-up of growth hormone treatment was the so-called SARCH study. You might have heard about it, which is a collaborative effort in between several European countries. And recently, the data from these 5 big countries were published, and in total more than 15,000 patients. And these data clearly show that in patients without cancer diagnosis at study initiation, i.e. growth hormone start, there was not an increased risk to a new cancer that could be related to growth hormone treatment. And the average follow-up time here was 17 years, and patient had reached up to 45 years of age. So far, in a very large cohort, with a very long follow-up time, up till 45 years of age, we can say that there is no increased risk of a new cancer. There was a growth hormone consensus meeting in 2016. I was there, and then we went through the whole literature and went through and found whether there are any evidences that could point to any cancer risk. And as you can see here to the left, risk for a new primary cancer in children, the conclusion was that there is no evidence for growth hormone treatment effect, and the level of evidence is robust, which means that there are multiple, more than 3 supportive publications. And the same is the case for adults. When it comes to recurrence of previous primary cancer in cancer survivors, there is also no evidence for growth hormone treatment effect in children, and here the level of evidence is robust. For adults, there are insufficient data available today to say whether there is an increased risk for recurrence or not. And this is patients that are started on growth hormone during adult life. What about second or subsequent neoplasm in a patient with an existing tumor at treatment start with growth hormone? Here, there is a risk most likely, but this risk diminishes with time from onset of growth hormone treatment. And this risk consists of an increased risk of meningioma in patients with brain tumors that have been irradiated. And it's important to know that if you irradiate the brain, you will get meningioma even without growth hormone treatment. And there is no evidence that growth hormone further increases this risk for meningioma. In adults, there is insufficient data. So the overall take-home message from this consensus meeting is that cancer surveillance beyond the local standard practice is not recommended in children and adults currently treated with growth hormone, nor in those previously treated with growth hormone including those with a previous malignancy. In other words, you don't need to have extra surveillance just because you have a cancer patient treated with growth hormone. So you surveil the patient just like you do with any cancer patient. No extra checkup just because of the growth hormone treatment. So that was an important part, cancer. Diabetic retinopathy. The question is here, are high growth hormone levels associated with deteriorating diabetic retinopathy? Although hyperglycemia is regarded as the primary cause of retinopathy, evidence suggests that elevated levels of growth hormone IGF-1 may contribute to its pathology. And there are case reports showing that growth hormone may be central in the initiation and progression of diabetic or proliferative retinopathy. Furthermore, there is an association between high IGF levels and deteriorating retinopathy. And finally, the prevalence of diabetic retinopathy decreases with growth hormone deficiency and diabetes. So, is growth hormone therapy contraindicated in proliferative retinopathy? Well, proliferative retinopathy or severe non-proliferative retinopathy is common in patients with diabetes. And a stable background retinopathy should not exclude or cause the discontinuation of growth hormone therapy. However, monitoring should be identified in the early phases of growth hormone therapy. Ongoing periodic screening is recommended. What about cardiovascular conditions? The relationship between the growth hormone IGF-1 axis and the cardiovascular system influences many cardiac events. First of all, development of the heart. There is a response to increased workload, inflammation, and also the growth hormone IGF axis has been correlated to increased angiogenesis and repair in the heart. So, growth hormone and IGF-1 excess will result in cardiac complications if you have an acromegaly, and concentric biventricular hypertrophy has been described, and cardiac derangement in a person with a cardiac disease, and finally hypertension and cardiac hypertrophy has been described. So, do safety concerns exist for certain cardiovascular complications? I would say yes, in a few of the diagnoses treated with growth hormone. If you treat a patient with Noonan syndrome, we should be aware that it increases the ventricular wall thickness, and it may also increase the incidence of cardiac adverse events. But we should acknowledge that there are conflicting clinical evidence. What about Noonan syndrome and growth hormone therapy? There are no association found between growth hormone therapy and adverse cardiac events in Noonan syndrome, and all cardiac dimensions remain stable. A relationship between growth hormone therapy and adverse cardiac events in patients with Noonan syndrome was considered unlikely in a study of 429 children. What about intracranial hypertension? We are all aware of this rare complication of growth hormone therapy, especially in the initial phase. So intracranial hypertension is characterized by increased pressure, headaches, nausea, tinnitus, papilledema, and optic atrophy and blindness has also been described. So obviously it's a serious but rare event. The annual incidence of intracranial hypertension in patients receiving growth hormone is approximately 28 per 100,000 treatment years. And there are higher rates observed in patients with certain diagnoses where you need to be a little bit more alert. So if you have a chronic kidney disease, Turner syndrome, Prader-Willi syndrome, or idiopathic short stature, a higher risk of intracranial hypertension has been described. So, what about the intracranial hypertension cases? Are they eliminated by cessation of growth hormone therapy? Well, the underlying mechanism of growth hormone therapy associated intracranial hypertension seems to be IGF mediated, and in the majority of cases, manifestation occurs 6 months after growth hormone therapy injection. In 22% of the cases of intracranial hypertension, it may not present until after 2 years. So when the growth hormone dose discontinuation or reduction, it usually eliminates intracranial hypertension, and if so, you can restart growth hormone therapy. The dose should be gradually escalated, and of course the patient should be closely monitored. What about thyroid metabolism? Growth hormone therapy affects the conversion of thyroxine to triiodothyronine, and in adults and children with hypopituitarism, growth hormone therapy results in, first of all, a reduction in T4 and an enhancement of peripheral deiodination of T4 to T3, an increase in T3, and last but not least, reductions in serum TSH. And growth hormone therapy affects also the peripheral metabolism of thyroid hormones. And the changes that can be seen, they are rapid in onset, they spontaneously return to baseline following completion of therapy, and they can unmask a previously undetected hypothyroidism. And there is a role of T4 substitution in these cases. So trying to summarize and conclude safety of growth hormone treatment. First of all, the majority of patients on growth hormone maintain adequate glucose homeostasis. Growth hormone therapy does not increase the risk of cancer in children or adults, but it should be withheld in patients with an active malignancy. And then you may ask, when can growth hormone treatment be started after completion of a cancer therapy? Well, I would say the recommendation is today to at least wait for a year after finishing cancer therapy without a recurrence of the tumor. Then you may consider starting growth hormone therapy. Thirdly, a slight increase in second neoplasm is observed in childhood cancer survivors treated with growth hormone, particularly after radiation therapy for a CNS tumor. And as I said earlier in the talk, growth hormone therapy is contraindicated if you have an ongoing proliferative retinopathy. And finally, growth hormone therapy has been linked to intracranial hypertension. However, these cases are eliminated by therapy cessation, and it is very rare unless you have these few diagnoses where the risk is increased, for example, renal insufficiency. So what about clinical practice, growth hormone therapy safety? I think the most important take-home message here is that as a healthcare professional, we should adhere to the approved indications and the dosing intervals when prescribing growth hormone therapy. That is the safest way to go. And we should also ensure that we regularly monitor not only safety but also the efficacy of growth hormone treatment. Because if the treatment is not effective, it's not only very costly, but you also take a risk, potential risk, which cannot be warranted. And by that, I would like to thank you very much. And if you happen to come to Sweden, you are most welcome to my home city, Stockholm. And this is a picture of the city center of Stockholm, where we have the Royal Palace here. This is the old city, the Stockholm City Hall. And Stockholm has been named the Venice of the North. There is water everywhere. The hospital is 2 kilometers up to the left here. This is the summer. At the moment we have snow and minus 4 degrees Celsius. Not so pleasant. And by that, I thank you very much for attending this late lecture and happy to take talk. Questions?
Thank you, Professor Lars, for that very elegant and informative lecture. The house is open for questions. I think Dr. IPS.
So I just want to tell you what a case we had, an SGA baby, he had come with cardiomyopathy. SGA with cardiomyopathy.
Cardiomyopathy in SJ, is that the question?
Yes. Yeah. So this child was started on growth hormone, being well followed by the pediatric cardiologist. His left ventricular fracture, he grew, but his left ventricular fracture also improved. He improved. His strength of the heart became better, and he was out of inotropes, everything, But he was taking some medication, all that was stopped. So even the cardiologist was quite surprised. And we looked up the literature, it is mentioned that it does help in dilated cardiomyopathy, the growth hormone. So what is your take on this?
It could very well be related to growth hormone. It's well described when you have pharmacological treatment with growth hormone that you can get cardiac myopathy and cardiac hypertrophy, just like your patient. And I think this needs to be carefully discussed together with the cardiologist, and you need to weigh the effect versus the risks of the treatment. But I would be very careful with growth hormone, and if treating with growth hormone, keep the dose down. But in SGA, you often need quite high doses of growth hormone. The cardiac hypertrophy you do not see in a patient who is growth hormone deficient. So it's like the SGA Noonan syndrome, this has been described. So I would be careful.
Thank you. I think there's one more question.
Yeah, you have already mentioned here there is no increased risk of cancer in a patient who is already having an existing cancer. But still I just wanted to confirm that child with craniopharyngioma operated post-radiation with residual tumor. We give growth hormone for short stature. Is it very safe that we don't monitor and keep on giving?
Yes, I mean, there are a couple of publications on craniopharyngioma and growth hormone treatment, and it's very clear that the risk is not increased. Having said that, me and I think most of the colleagues wait 1 year today. Earlier it was 2 years, just because if you get a recurrence or growth of the tumor, it's very easy for at least for the parents to link this to the growth hormone treatment, and then it's very difficult to start growth hormone at a later stage. So the advice is to wait a year before you start with growth hormone therapy. Regarding the dose of growth hormone treatment in a cancer survivor, the quite recent consensus guidelines with the first author, Scott Sklar, which was published last year in JCNM, it is recommended to use the full approved dose in a cancer survivor. I must say that my own personal experience is that it works very well with a lower dose. So I usually titrate up to an IGF-1 in the mid-normal range. You don't need to titrate it higher in a cancer survivor, and they still grow very, very well. So that's my personal practice.
I just had one question for you. In a patient who has existing scoliosis, is growth hormone a contraindication?
It is, I mean, a warning for scoliosis on growth hormone treatment, and there are data published there, and it's very clear that when you grow more or have accelerated growth, irrespective of growth hormone treatment, your scoliosis is likely to worsen. But there is no data linking this to the growth hormone treatment itself. So I think this is just a consequence of accelerated growth, whether that is driven by an endogenous puberty and growth hormone IGF-1 stimulation or exogenous growth hormone. I don't think it really matters, but you need to be careful, and if the scoliosis is really severe, of course that weighs against treatment.
Okay, thank you.